I'd like to tell you a little bit about the Jan Stewart Wellness Lecture Series. Jan Stewart served as AANA president from 1999 to 2000. In 2002, Jan died unexpectedly of an accidental, self-administered overdose of sufentanil. This led to the realization that no one is immune from the risk of addiction, and when the risk is ignored, our whole profession loses. This realization became the impetus of the AANA Wellness Initiative in 2004 and was also the beginning for today's AANA Health and Wellness Program. To continue Jan's legacy, the Jan Stewart Wellness Lecture Series was established also in 2004 to feature speakers on wellness topics at each AANA Nurse Anesthesia Annual Congress. We are pleased to have Jan's daughter, Sarah Stewart Gomez, with us today to introduce the 2014 Jan Stewart Wellness Lecture Series speaker, Anita Bertrand.
Good morning. I am pleased to be here again to be with you all, first of all, and to enjoy the 11th annual wellness lecture. My mom believed in the power of her peers and this association, and the wellness program has grown from that spirit. Today, we are working together to know better the hazards of this profession that lived far too long in the shadows. And also through the wellness program, we are not only bringing awareness and peer assistance to people who need it, but also living healthier, happier, and prosperous lives from the broad-reaching programs that have come from your work together. This profession has come a long way in the 12 years since my mom's death, and our speaker today is a testament to that. Anita Bertrand is a CRNA who experienced substance abuse and addiction after 15 years practicing in the nursing field. Through her experience, her treatment, and recovery, she has experienced firsthand incredible knowledge of this disease of addiction, how it manifests, and how it is treated. Recovery from the active disease has given her the opportunity to return to anesthesia, as well as guide other nurses and CRNAs who are suffering from the disease and seeking treatment. In her role as State Peer Advisor for Texas and a member of the Peer Assistance Advisory Committee, she sees the devastation that occurs with this disease and the lives of CRNAs, colleagues, and their families. But she also gives us hope that we can help each other. Today's lecture is Making Lemonade, One CRNA's Story of Addiction and Recovery. Please help me welcome Anita Bertrand.
Wow. Good morning. Thank you, Sarah, for your words and encouragement and sharing of your mother's legacy so that all can learn from it. Jan Stewart is a huge inspiration. First, in her life as an example of service to our profession, and secondly, in her death, she speaks to us, letting us know that if this can happen to her, it can happen to anybody. I'm extremely grateful to have survived my disease of addiction. And I'm even more grateful to be able to share that here with you for the simple miracle of living beyond that disease. It's an honor to share a little bit of what Jan must also have experienced. And by doing so, to help save somebody else's life. Thank you all for being here, because this is about you. This is about those of you who will suffer from this disease at some point in your career. This is also about those of you sitting here who must support those people because they depend on you to live. Their disease will kill them unless somebody helps, because they are unable to get help for themselves. So you have a vital role in identifying our colleagues when they are in their most vulnerable state and are unable to help themselves. A little over 9 years ago, an event happened in my life that flipped the switch, that turned on the disease of addiction, that sent my life spiraling downhill into a path of destruction. I became addicted to the very drugs that we are entrusted with to administer to our patients. Fentanyl at first, and when I was withdrawing from fentanyl, propofol became the answer. It was a 10-month period swallowed up in a disease that no doubt would have ended in my death, if not for a chance encounter, or maybe grace. Prior to this event, taking from the cookie jar, so to speak, was beyond me, because I knew that I would never choose to do such a thing. And I really couldn't understand, how does this happen? When I learned of Jan's death, that was my thought. How does this happen to someone who has achieved so much in their lives, and to simply throw it away so quickly? It was unfathomable. I had worked too hard to ever let that happen. In September of 2005, my husband, my daughter, and I went on a vacation. We traveled to Europe for a 2-week bicycle trip along the Danube River. This trip was significant only in that it became a marker in determining how this all got started. When I arrived in treatment, basically shoveled under the door and said, show up here. They told me it doesn't matter how you end up here. What matters is that you got here. And that was very true. A few more weeks of doing what I had been doing, and the outcome would have been very different. As my head started to clear and I started searching for answers, how did this happen? I thought I knew better. At one point, I recalled on my flight home from Europe having the thought, okay, I've been gone for a little while. I shouldn't have to do this anymore. I should not have to do this anymore. Time away on vacation, time away from work, time away from the drugs. I shouldn't have to do this anymore. To stop diverting, stealing fentanyl, self-injecting on a regular basis, daily, multiple times a day, in between cases. Just having that thought, I should not have to do this anymore, was a very clear indication that my brain was already hijacked. More importantly, those thoughts indicate that on a subconscious level, I did not have control over what was happening. All along this journey, I held on to the belief that I should be able to stop. I believed I had control over this disease. Prior to the event that was my trigger that turned on the switch of the disease of addiction, I truly believed that because I knew better, and it was something I would never consider doing, that I had control over this happening. And then while in the midst of addiction, I continually believed that I could actually single-handedly make a decision and stop doing it. It was a daily ritual. I woke up in the morning, got ready for work. I prayed, God, I don't want to do this anymore. I drove to work, still determined I was not going to do this anymore. I go in and I draw up my drugs, and I couldn't help but draw up my fentanyl in 2 or 3 different syringes, just in case the patient didn't need all of it. Simply making the decision and simply wanting to stop did not allow me to stop. After all, we get here, we make decisions, we have control over our lives. That's how I became a nurse anesthetist. I made a decision. I wanted to do this. I worked hard. I made the right choices, and I controlled the outcome. In this disease, there's no controlling the outcome. The disease is in control. The progression of this disease, because of the behaviors that are exhibited in active addiction, leads only to jails, institutions, and death. Too many nurses, too many nurse anesthetists, too many healthcare providers, like Jan Stewart and many others. The progression of this disease has led to death. When the disease is arrested by an event that leads to jails or institutions, hospitalizations, we have an opportunity to get treatment, but we cannot fix dead. What does it mean the brain is hijacked? In the disease of addiction, the brain becomes hijacked differently for different people at various times. Some people, one exposure is all it takes when someone is particularly susceptible. Others, it's over a course of many exposures, which is typical of alcoholism and other street drugs. The drugs that we use in the anesthesia field, they're like rocket fuel. All it takes is one time for some people. The brain site where the drugs affect is in the midbrain, called the limbic system. This is the reward pathway, the ventral tegmental area, which projects into the nucleus accumbens, and then from there, multiple projections into the prefrontal and frontal cortex, where consciousness occurs. But the actual addiction, the release of dopamine that stimulates and hijacks the brain, happens in the midbrain. It happens below conscious control. An example of how this happens is the memory of an exposure that leads to saliency is imprinted in the brain, and it goes back and forth, and it drives a person to do whatever it was. If that means survival, if that means eating, if that means getting shelter. This is a very primitive part of our brain that has driven us to evolve to the brain that we have today. And there's a feedback control of this drive. which is represented by the blue circle. That's the normal pathway. In an addicted brain, that memory and that saliency that happens because of the flood of dopamine makes that drive huge. Not only does it make the drive huge, it also pretty much blocks that feedback control. It hijacks the brain so that all of the neuroplasticity that goes to the prefrontal and frontal cortex is shut off. So the person is not able to make decisions. It's not able to control his behavior in regards to this disease. The brain is in control. And the brain, because it has evolved over time to be satisfied and to seek survival, it's in control. And that's what the drugs become. There are many reasons why this happens to CRNAs. Why is addiction the #1 occupational hazard for nurse anesthetists? There appears to be a genetic susceptibility to addiction. How much a role this plays into the development of the disease is not known, but the susceptibility is there if one has a family history of alcoholism or addiction. And that person is particularly susceptible if exposure or access occurs. My father was an alcoholic. Many of his siblings were alcoholics or died from complications due to alcoholism. A childhood of shame and hiding of the nature of the home environment and the fear of what would happen next when the head of the household is an alcoholic instilled in me a determination to make a change. I would do something different. I would be successful in my life. I would not live this kind of lifestyle. Well, some things we can change. We can change our jobs. We can change our friends. Sometimes we can even change our families. But we can't change our genes, at least not the ones we're born with. There is considerable association between addiction and other psychopathology. It's been suggested that one source of motivation for the self-administration of addictive drugs is the self-medication of symptoms that are associated with comorbid psychiatric diseases, such as depression, bipolar disease. Along with that, life's events, traumatic events, injuries, when untreated or not dealt with in a healthy manner or an appropriate manner, may result in the desire to self-medicate whatever is ailing them in order to be relieved of the escape of these life experiences, in order to be relieved or escape from these life experiences. Sensation-seeking, impulsive personalities. These are personality traits that have been associated with substance abuse and are traits that are intrinsic in nurses who seek a career in anesthesia. These are traits that actually work for us in our profession in order to do our role well. We see exactly how these drugs work on our patients. We see these patients come in, they're extremely anxious to have surgery. We give them medication, and one day it's, wow, that's amazing. How does that happen? The next day, under a very stressful environment or an event that's happening in one's life, man, I sure would like to have some of that. So before long, that curiosity of what is that like has established a path of destruction that is like a runaway train. Stress, both personal and professional stress, are associated with developing the disease of addiction. We all encounter stress. We have to learn how to effectively cope with it. We never know when life events are going to overrun our ability to cope effectively with the stresses in our lives. And so someday, having access to very potent addictive medications in an attempt to relieve some of that perceived stress, to escape, to get away from it. All it takes is one time. And somebody is on that runaway train. All of these events can happen singularly or multiple events at one time, and an individual does not become an addict and does not become an alcoholic. But when all of these events line up in a certain way with particularly susceptible individuals, they're on that runaway train. No one of us in this room is immune to this disease. Not a single one, no matter how determined and how much you think that this would never happen to you. The majority of you sitting here can account for all of these risk factors. There are times that these risk factors play a greater role than others. As a population that is aging, we are also experiencing chronic progressive diseases. And life happens. Accidents and injuries. And we need medical care, we need surgery. And we're exposed to addictive drugs in these processes. And then we go back to work and we have access to these drugs. In my previous years, 10 years as an ICU nurse, 5 years as a CRNA, it never occurred to me to divert fentanyl and self-administer. It was a very clear line you just did not cross. Believing, understanding that a disease, or that alcoholism and addiction is a disease, I truly did not understand how this can happen to somebody. In the beginning of August of 2005, I had a bowel obstruction. I had a bowel obstruction due to fibroids. This was diagnosed after a few weeks of on and off vomiting, not understanding the reason why, really not knowing why this happened. The discovery came 5 weeks before this planned trip to Europe, to bicycle for 2 weeks. So that was a big impetus to, we've got to take care of this now. So I can get back on that bicycle and go on our trip that we'd been planning for many months. For post-op pain, I asked my anesthesia group to give me an epidural so that I would not have to take IV narcotics or PO pills until I went home. So I received the epidural, and I spent the first day extremely groggy and sleeping, and remained that way the next day. And upon awakening, my CRNA friend that was staying with me, my husband was home with my 2-year-old daughter. My intention was to spend a couple days in the hospital reading some books, watching some TV, things that a new working mom doesn't get a chance to do. And I couldn't. I was falling asleep. I could not even have a conversation with my friend. So finally, we stood up and we looked at that epidural infusion. What is in this thing? I discovered it was mixed with fentanyl, 10 mics per cc, and I was receiving 10 cc's an hour. 100 mics of fentanyl an hour in my epidural. I thought, oh my gosh, no wonder I'm so sleepy. And after some time, I called the anesthesia group and I said, please just take this thing out. I don't need this. I took post-op pain medication as prescribed. Went back to work 2 weeks later. No medication, no pain, ready to go on my vacation. I had 3 weeks to work before vacation time. It was later in treatment that I realized something happened. Something happened before my vacation, but after surgery. Because I recalled that before surgery, it was never even a consideration. But sometime between returning to work and going on vacation, I remembered having a thought. I remember the room that I was in when I had this thought. I remember the type of procedure that was occurring. I remember the surgeon that I was given an anesthetic for. And I remember thinking, why waste this extra fentanyl? Maybe it'll make me feel better today. There was nothing wrong. I was not in pain. I was not hurting in any way. But I just had that thought. And at some point, I don't know if it was that same day or if it was a couple days later, the next day most likely, I started taking that waste and self-administering it. So that on that trip home from Europe, I had that thought, okay, I've been gone for 2 weeks now. I should not have to do this. I do not want to do this anymore. It was against every part of my being to be doing what I was doing. But I did have to do it, and I would continue. By the end of June 2006, about 10 months later, I was working in a small outpatient surgery center, one of 4 different locations where I was working as a contract CRNA. I was found unconscious in my car, parked in the parking lot next to the anesthesiologist that I was working for. I had a hip lock in my ankle, and there were empty vials of propofol and syringes and other paraphernalia lying in the car that was visible to the anesthesiologist. Apparently, the door was locked, and at some point I woke up. When I came to, the 2 anesthesiologists were sitting there with a wheelchair, and they were talking to my husband on the phone. And I heard him talking about a treatment center that I was very aware of. And my thought was, how did he know about that place? The only way he would know about that place is he had talked to my friends. And somehow somebody told him where I should go. He'd also arranged for an interventionist to come in and do an intervention on me. Because the night before that event, I had put my daughter to sleep, and in my attempt to avert the horrendous shaking and tremors of withdrawal, I had put myself to sleep with a little bit of propofol. 5 cc's at first, and then when that goes away, I never lost consciousness, but when that goes away, I would shoot in the rest of the syringe. Apparently, he found me unconscious on the floor next to my bed, distorted in a way that he thought I had broken my neck. So he stayed home the next day to research what's going on. And he found a treatment center, and he had me pre-admitted someplace to go. I share the details of these events for the sole purpose of demonstrating that even though I remained functioning as a mom, somewhat, as a wife, as a nurse anesthetist, administering anesthesia on a daily basis, while self-administering fentanyl in between cases, nobody suspected. But I was still incapable of making decisions about my own health and my disease when I was in the environment where I had access to my disease. The irony of all of this was very evident to me when I returned back to work as a CRNA. My very first patient, when I dropped him off in recovery room and gave report to the RN, he looked at me and said, "Can I drive myself home today?" And I thought, no, that'll get you in trouble. Why didn't anybody know? How is it that we have to die, nearly die, or be found dead before anybody knows? The addict becomes extremely adept at hiding and deceiving. Remember, this is a brain that has evolved and become quite successful in surviving under the worst circumstances. So the behavior dictated by the hijacked brain is quite remarkable. On top of that, our work settings are perfect for hiding. We work independently. We're in the room by ourselves. We're in control of our medications that we administer to our patients. And on rare occasions, somebody else is overseeing something or watching what's going on. Occasionally, somebody might get a little piece of the puzzle, relieve you for a bathroom break, and you come back and you might be a little dazed, but you explain it away. They trust you, they believe you, because they've worked with you for a long time and they know you. It's just a fleeting thought. Others have fleeting thoughts, but nobody gets the big picture, because these fleeting thoughts are just pieces of a puzzle that are scattered, and they never get put together because there's no central source to share this information, nor do we feel like it's important enough to share with somebody that's in charge and that would have the big picture. As a fentanyl-addicted CRNA, my drug of choice was at work. So I showed up at work. I was there on time, usually before my cases started. I was willing to do the biggest cases because those cases were the cases that allowed me to divert the most fentanyl without it being evident. And my patients were taken care of, so I thought, because I knew that would be one of the signs. If my patients were hurting in the recovery room, somebody would suspect something. So I made sure the patients got enough narcotic. I just checked out a little bit more so that I would have some. The long shifts, the after hours with less people around provide opportunities to hide, the opportunities to divert on one's own patients, or even to divert and falsify records on somebody else's patients in the afternoon when everybody else is gone. The records haven't gone to the pharmacy yet, so I could pull out drugs on somebody else's patients and just chart on their record. Nobody would know. The withdrawal from life occurs. Withdrawal from relationships, both personal and professional. Withdrawal from family activities, or an overall lack of just not being around when you were physically there. At one point in my disease, I had a moment of clarity, but it really wasn't a moment of clarity to help me to get help. It was a manipulation for the disease to be able to continue. I was planning on changing my job and working for a friend of mine, which required me to be away from home for periods of time, with the potential that this job would offer long-term employment. And so I was trying to convince my husband to change jobs and find a job in this smaller city, because I thought it would be a good place to raise my daughter rather than the big city of Houston. And he wasn't too convinced. So in an effort to convince him, I shared with him what was going on. This was about 3 to 4 months into my disease. I shared with him that I've been trying to stop. I can't stop. I need to go to treatment. But at the same time, convincing him that treatment was expensive Treatment meant I was going to be away from home for 12, 14 weeks. Treatment meant everybody would find out. Treatment meant that I would not be able to work as a nurse anesthetist anymore. Treatment meant that we would lose our house. All of these very undesirable things would happen. So therefore, I needed to change my job. If I changed my job, then everything would be okay. I would be working with different people, new people, and I would behave. I would act professionally, and I would not do this anymore. So he bought it. But at the same time, I told him, you can't tell anybody, because all those things would happen. And he believed me and he trusted me. But it just provided more opportunities for the disease to continue to progress. At some point, I even went to my priest, thinking that I could get help in a confidential manner so that I would not be reported to the Board of Nursing, and I would not lose my job, I would not lose my license. And he tried, but he came back with the response that nobody would be willing to accept that responsibility. And so again, my disease continued to progress. As a rule in the hospital, we can hide it pretty easily. It's cold in the operating rooms. We wear long sleeves. So the IV drug use was easily hidden. I used all of my skills and my education, or I guess I didn't use it. My disease used everything about me against me. I inserted hep locks constantly in my ankles, places where they were hidden so that nobody would find out. I even remember thinking at one point of a way to put a central line in so I wouldn't have to keep putting peripheral lines in. A mirror on the wall or something. It never evolved, thank goodness. Frequent bathroom breaks, leaving the units, not being reachable. I knew all those things were symptoms or signs of this disease. So I stayed at work. I went to the bathroom between every single case because nobody was going to accuse me of taking frequent bathroom breaks. But I used every time I went to the bathroom too. This progressed for 10 months before being detected professionally. What were the real reasons I could not get help? I wish it had been as simple as, I have a disease like diabetes, arthritis, heart disease, and I need to get treatment. But it wasn't that simple. Fear and shame. Those two feelings paralyzed me. The shame was insurmountable. I was very much aware of what I was doing was against everything I believed in, personally and professionally. And I did not want to continue. And how was I going to face you? How was I going to face the anesthesia community? We all know the stigma that surrounds this disease. And I could not bear that thought of facing my colleagues in the anesthesia community. There are no words to describe that immense shame. I frequently thought of Jan Stewart and how immense that shame must have been as a former president of our professional organization. How immense that shame must have been. During the first week of treatment, the treatment center has this ceremony they called Romp and Stomp, where patients who were going to go home were able to share a few words about their experience in treatment, and new patients were introduced to the recovering community. It came around my turn. I had to stand up, Hi, my name's Anita. I'm an addict. I'm from Houston, Texas. I'm a nurse anesthetist, and my drug of choice, and before I had a chance to even vocalize, the entire room shouted back at me, fentanyl. Incomprehensible demoralization. There had been enough anesthesia providers go through this treatment center that the entire community knew the drugs that we are most likely addicted to. Upon returning home from treatment, it was sheer terror just to go out my house and go to the grocery store for fear that I would run into one of you, and one of you would know exactly what I was doing. The fear of what was to happen once discovered and treatment was sought, what would happen to my license and to my career. I knew exactly what the consequences were. I had previously assisted on an intervention for one of my colleagues who was alcoholic. And we intervened and we sent her off to treatment to the exact same treatment center that I went to. I knew exactly the consequences of having to enroll in the monitoring program in my state and not being able to work for a minimum of a year as an anesthesia provider. And if I was allowed to go back to work, I could work as an RN with a narcotic restriction. Now, really, who's going to hire a former CRNA with a drug addiction as an RN with a narcotic restriction? Who has time for that? With the intention that as soon as this year was up, I was going to return right back to anesthesia. You know, I knew that I could not work. That fear paralyzed me and prevented me from getting help. I remember in the midst of my disease of another CRNA who had been discovered and had been intervened on, and as I called a friend to find out if this really was true, I remember during the conversation thinking, I'm going to have to be smarter than she was. I'm just going to have to be smarter than she was so I don't get caught. Well, I did get caught, and I am extremely grateful to the anesthesiologist and to that chance occurrence that happened. When I went back to speak to that anesthesiologist later to thank him for the care and the compassion that he showed me on that day when I was in my most vulnerable state, he told me, he said, Anita, I don't ever park on that side of the building. I come from a different direction. I don't know why I was parked next to you. I know why. I went to a treatment center that is well known for treating healthcare providers. In fact, the physician himself was an alcoholic and developed this treatment center for healthcare providers. I don't know how I ended up in this particular treatment center. I knew about it. I never told my husband this is where I needed to go when I told him I needed to go to treatment. And sure enough, that's where I end up. Because he stayed home that night before and got online and started looking for facilities of CRNAs addicted to fentanyl and where they should go, and found an article written by this particular physician and had me pre-admitted and had arranged for an interventionist to come fly in from California to do an intervention on me. But that wasn't necessary because I was done, and I was grateful to be done. I didn't know how I was going to face what was to come in my life, but I was glad to be done. So treatment is necessary, particularly for healthcare providers, for it to be inpatient, long-term treatment, minimum of 30 days, preferably 90 days. There needs to be an addictionologist who's board certified by the American Society of Addiction Medicine, and even a psychiatrist who's board certified as well to deal with the comorbid psychiatric problems with addicted healthcare providers. And the treatment center needs to be based on the 12-step model of abstinence-based recovery. I was a pretty tough nut to crack, because not only did I spend 12 weeks, I ended up buying a few extra weeks on my return home visit to set up my aftercare. Because when I was in treatment, it was easy to stay clean and sober. Alcohol had not been my drug of choice. I could take it or leave it. And being in treatment, I had no access to fentanyl or propofol, so it was pretty easy to be away. But on my return home after 12 weeks to set up my aftercare, to set up my 12-step meetings, and to have a trial experience of being home, I decided I needed to go back to the hospital to say hello to the anesthesia group who had supported me and who I secretly was hoping that I would get a job back. So I went to the hospital. I pulled into the parking area where I normally parked and swiped my badge. It didn't work. No surprise. Okay, Anita, you don't need to be here. So I left. Went a few blocks, turned around, and came back to the visitors' parking lot. I sat there for a few minutes thinking, well, maybe I really should not be here. And I turned and left again. Got a little further away, but turned around again, parked in the visiting parking lot, took a few things out of my purse, and proceeded to walk into the hospital, to the OR. Visited with everybody in the hospital. In the operating room, many people came out, gave me hugs. It was great to be accepted and supported. And at one point, one of the anesthesiologists came in with a set of scrubs and said, "So-and-so is in a room. She can't get out. Go say hi to her. She wants to see you." That was my ticket. Put on my scrubs, carried my purse, took a roundabout way to get to her room. Somebody had set up fentanyl and propofol in a case ready to go. Nobody was in the room. Walked through, swiped the syringes of drugs, threw them in my purse. Went over, said hi to my friend, left the OR, visited some more, even received a phone call from my husband. At that point, I knew I couldn't open my purse, so I didn't answer the call. I left the hospital, went out to my car, and used that propofol, and then proceeded to drive home. Convinced my husband to take my daughter somewhere to do something, so I was left home by myself. He was only gone for a few minutes, and he came storming back into the house because he found a needle cap with some white stuff in the pocket of this rental car. Was absolutely livid, understandably. So I went back to treatment with a little less shame because I realized I missed something. This should not have happened. I missed something, so it bought me a few more weeks. And I'm grateful for that experience because this disease is chronic, it's progressive, and relapse is common and is a normal part of this disease. However, for us, we don't have that luxury because a relapse oftentimes means death. Getting home from treatment was not an easy thing, as I mentioned before, the shame and the guilt. and the unknown of where life was going to go. Fortunately, my husband, through the encouragement of his parents, stuck around to see this through. Frequently, that doesn't happen, and I cannot blame those who choose to run. It is an arduous return to living life again. I focused on recovery, doing what was required. Having the luxury of a working spouse, I was able to not work during that year that I was required to not provide anesthesia, and focus on recovery so that I would be safe and I would have a strong foundation if the opportunity arose that I could return back to anesthesia. I did have some financial resources for retirement. I decided I might as well use those now because I'm not going to be around for retirement if I don't. When permission was granted by my monitoring program, I began the strategies for returning to work. That time away was the single most important thing that I could have done for my recovery. That time away focus on recovery. Many people do not have the luxury of returning back to anesthesia after 15 months. Those that return after 2 or 3 years also say that that time was the most important thing. I will always be grateful to the 2 anesthesiologists who gave me a chance. They heard my story, and they gave me a chance to get my life back. Shortly after my monitoring program, I learned that the great state of Texas did not have a peer assistance advisor. So I stepped up to the plate. I know what it's like. I can take those phone calls when somebody's in that place. I understand. My very first hotline call came from a student nurse anesthetist who had been discharged from his anesthesia program because of addiction to fentanyl. He was working as an RN, and he started to work as an RN after he'd gone to treatment. And I spoke with him and explained the path to return, what was going to happen, and I encouraged and supported him. Later, I learned that he had taken some action to commit suicide and only successfully achieved putting himself in a state where he would always be dependent on somebody else. The devastation of the disease and the fear and the shame of this disease that could have been me if not for the grace of a higher power who has provided a path for me so that I can be here to share this story. You need to fully understand this disease. We all need each other. There is nobody in this room who is immune to this disease. Some of you were handed lemons as you walked into the room. Raise those lemons. Better yet, stand up if you have a lemon. Wow. Look around this room. This is a visual of the number of people that are going to be affected only in this room by this disease at some point in your career. Remain standing. Stand up. In most cases, you cannot and will not get help for yourself. Hopefully, you will get caught before you accidentally kill yourself. You need everybody that's sitting around here to look out for you. You need them to identify you, to scrutinize your behavior. They need you. You need them to question you, to call you out, and then to not believe a word you say. Because your denial is so big that you will manipulate and you will convince them that they are wrong. Those of you that are sitting here need to go to your chief CRNA, go to your employer, go to your boss. Share your glimpse of what you see in the behavior of this person standing, so that somebody gets all the pieces together, so that you can be identified before you kill yourself accidentally. These people that are standing do not need your condemnation, your criticism, your judgment. They need your support. They need your phone calls. They need your encouragement, so that one day they may be able to survive and provide for themselves again. Those of you that are standing, some of you have a lemon that has a little dot on the bottom. You remain standing, the others can sit down. There's a few of you that have dots on your lemons. We will not know about your disease until you are found dead. We can't fix dead. But hopefully, as you die, your spirit will enter the soul of somebody else in this room, so that they can be inspired like Jan Stewart did for me. Thank you.